everyone ready? Hello? Can you hear?
Yes, doctor, we can hear you.
Everyone
Now
dah ready semua?
36 participants.
Out of 42, right?
Yeah.
I think we can start. How many presenters today?
There will be 3 presenters for today, 3 or 2 presenters.
And then tomorrow 3 or 2, right? Total of 5. 5
Yeah,
presenters. Okay. Can you first topic what we have today?
excuse me, doctor.
Our first topic is
So our first topic will be pleural fluid interpretation by me.
okay, you can start.
Okay.
Hello? Everyone can hear?
Hello, sorry doctor. Aku
Mute dah.
okay.
Let's start again.
Alright. Sorry doctor. Okay. Assalamualaikum and good morning everyone. My name is Azra. So I'll be the first presenter of today's presentation. My topic is about the pleural fluid interpretation. So first thing first, we go to what is pleura. Pleura is really the ones that lines the pulmonary cavity and the external surface of the lung. So it can be divided into 2 layers, which is the parietal layers and the visceral layers. The parietal layers lines the inner thoracic wall, and the visceral layer lines lines the lung itself. So parietal layer can be further divided into 4 actually. The names is correspond to its location. First, we have copula at this cervical and costal, diaphragmatic and mediastinal. Another important structure that we need to know is the pleura cavity. It is a potential space between parietal and visceral pleura, which contains small amount of serous fluid to allow sliding motions of a pleural surface during respirations. So this is the content of normal pleural fluid. It is clear in color. It has white blood cell count less than 100 per millimeter square, and it has amylase and pH 7.6 to 7.64. Glucose, which has similar concentration to plasma, triglyceride less than 2, protein in between 1 to 2, and lactate dehydrogenase less than 50% of from the plasma concentration, and cholesterol 3.5 to 6.5 millimole per liter. This is the pleural effusion. It is a condition where there is excessive accumulation of fluid within the pleural cavity. pleural fluid accumulation is actually a result of disruption in the balance between productions and reabsorptions of the serous fluid just now. Uh, so pleural effusion occurs either when the production exceeds reabsorptions or when the mechanism of reabsorption have disrupted. So the more common cause is mechanism of reabsorption has been disrupted. So one few causes of pleural effusion is increase in hydrostatic pressures, such as in congestive heart failure, increase in vascular permeability, such as in pneumonia, decrease in oncotic pressure, such as in nephrotic syndrome, you lost when we lost a lot of albumin and oncotic pressure decrease, and also increase in intrapleural negative pressure in conditions such as atelectasis, and decrease in lymphatic drainage, such as in mediastinal carcinomatosis. So this is just diagram of pleural effusion, and the one below is diagram of pleural effusion in chest X-ray. You can appreciate pleural effusion from the loss of costophrenic angle. So we can actually pinpoint the causes of pleural fluid from uh, the type of pleural fluid that's been produced. We can send the pleural fluid for investigation and analysis, and we can see whether it is transudate or exudate. So different causes produce either transudate or exudate. So transudate is produced when fluid is pushed through the capillary due to high pressure within the capillary itself, such as in increased hydrostatic pressure in congestive heart failure. And it's also occur when there is increase in pleural permeability or low oncotic pressure, such as in nephrotic syndrome. Uh, Meanwhile, for exudative, fluid is formed from the leakage around the cells of the capillary caused by inflammations. So when we have inflammation, the cells become more separated and fluid can leak in between the cells. It caused by changes of local factor, cytokines, mediators, and all. So the causes of it is malignancy, infection, pulmonary embolism, and trauma. This is the diagram between the difference between transudative and exudative pleural effusions. So you can see from the diagram, exudative, the cells are separated. So large components such as protein and lactate dehydrogenase can pass through the capillary and enter the pleura. So the exudate has high in protein and LDH. So if transudative, it occurs due to increased hydrostatic pressure and low plasma oncotic pressure, just as mentioned before. So the cell is not as separated as in exudative. So the only fluid, low protein and LDH can pass through. It cannot pass through protein. So from our analysis, from the light criteria, transudate contains less than 0.05, the ratio between the pleural and serum protein, and pleural between serum LDH is less than 0.06. Basically, transudates has lower protein and LDH level, and exudates has greater protein and LDH level. This is the main causes of transudate pleural effusion, and this is the causes of exudate pleural effusion. This is just another criteria to differentiate exudative and transudative. It's similar as before actually. So this is other criteria that we can look through to differentiate the causes. First is about the color. If the fluid is purulent, it may be emphysema, pus. Milky fluid can be cyclothorax and pseudocyclothorax. I will further elaborate about this later. And if it's grossly bloody fluid, it can be it is most probably from trauma. And strong colored fluid with smell of ammonia can be urinothorax. And food particles in conditions such as esophageal rupture and blood pleural fluid in Aspergillus niger infection. So when pleural fluid has lactate dehydrogenase levels more than 100 IU per liter, which means it is an exudate, it can be caused by emphysema, malignancy, rheumatoid effusion. And pleural fluid glucose is also important for us to know. When there is low level of glucose, it may indicate emphysema, rheumatoid effusion, and also infection. Next one is about the pH. It is if the pH is less than 7.3 or just now is 7.4, it is most likely to be associated with the same pathologies that cause the pleural fluid glucose to be low, like the causes I mentioned before. So the next one is pleural fluid amylase. If the amylase levels is greater than 110 IU per liter, it may indicate pancreatitis, ruptured esophagus. So the white blood cell count, if less than 1,000, it is transudate. If exudate, it is more than 50,000 cells unit. So for pleural cholesterol and triglyceride, so this is cyclothorax. If the condition of cyclothorax, the triglyceride is more than 1.24 millimole per liter, and carbohydrate cholesterol is less than 5.18 millimole per liter. It is due to blockage of thoracic duct that transfer lymph fluid from intestine back to lymph node. The other condition is pseudocyclothorax. It is a condition where the triglyceride is less than 0.056 millimole per liter and cholesterol is 5.18 millimole per liter. It is caused by long-standing of pleural effusion, large amount of cholesterol can accumulate in pleural fluid to produce xyliform pleural effusion. So this is just a table that says the criteria that would support diagnosis of pleural infection. I think that's all from me. I pass the floor to Daniel Kueh if there's no question.
Azra, I think I have a question. Could you please elaborate more on rheumatoid effusion?
So rheumatoid effusion, we know that rheumatoid effusion is a condition which is related to autoantibody that trigger the inflammations. We know that when there is inflammation, there is increase in capillary permeability. So it will cause fluid to move from the capillary to the pleural cavity.
Oh, faham. Dari autoimmune diseases.
Rheumatoid
Ah.
causing inflammation. Is that okay?
Faham.
Alright.
Okay. Thank you.
So I think that's all from me. Thank you.
Wait a minute, I'm trying to share slide. Can you guys hear me?
Yes, Daniel.
Okay. So for my part, I'll be presenting on the ABG. So what is an ABG? Is that we use basically we use ABG, take the blood from the arterial. We want to measure the oxygen tension, the carbon dioxide tension, the pH, the oxygen hemoglobin saturation, and bicarbonate concentration. So from here, I put the equation. Later on, you'll see the significance of the equation. So from the ABG analysis itself, you can see whether the effectiveness of oxygen exchange, oxygenation of blood through gas exchange in lung. You also can see the CO2 elimination through respiration, and then you can detect acid-base imbalance in CF. So now I'll show the video on how to detect ABG. Never mind, since I cannot play the video, but I already sent it in the group. So basically, in order for you to first decide if you want to take the blood, is that you, for example, usually they take from the radial artery, right? So they will feel the pulse, right? But in order for you to take from the radial artery, it is very important for you to make sure that you have a good collateral flow. So how do you want to ensure there's a good collateral flow? Is that you have to ask the patient to grasp their palms. So they have to genggam tangan dia. And then while they genggam the tangan, you have to press on both radial and ulnar artery. So why do you want to do that is that you want to stop the blood supply, and then after that, by a few seconds, your palm will turn white, right? So since you wanted to take the blood from radial artery, so you would release your finger from the ulnar artery to see that if your ulnar artery can perfuse to your palm. So if there is a perfusion in like roughly 7 seconds, that after you release your occlusion on the ulnar artery, that your palm start to turn red again, it means that you have a good collateral flow, then which allows you to take the blood from the radial artery. So when you want to feel the when you want to take the radial artery, you can refer to the video. But most importantly, it is stated that it is preferable that they use some sort of like lidocaine to like make sure that it is not painful for the patient. But it is also very important to note that sometimes when you puncture the artery, you would accidentally go through the vein too, which is why you will get a mixed picture for your ABG. On the next slide, I will explain on the normal value. It is very important for you to know the normal value before you want to interpret. So there is 5 things that I want to focus on, but mostly just 4 things. The very first is the pH. The second is the carbon dioxide. Third is the oxygen level, and then also the bicarbonate ion, and then the best excess. So very first of all, I want to discuss the first parameter, which is the oxygen itself. So if we see that the patient have, for example, a low oxygen, right? So it indicates by looking at the oxygen level, we can see whether the patient is hypoxic or not, the partial pressure of oxygen. So then, usually in a normal value, and I already put that it's 75 to 100. So then under room air, it is supposed to be more than 75 mmHg to 100. But if it's more than 100, is that good? It's not really good, because we learned, even in kids before, we learned that if you give too much oxygenation for baby, for example, then they would have some sort of oxygen toxicity, especially would affect the retina and all that. So it is not good. However, not good. So you have to make sure that it is within the normal range. So why is it above 75? This is just some sort of like, it's not that important, but it's something you can use to understand is that first. So when we go to the ward, right, we write under room air, under room air. Under room air is in atmosphere, how many percentage of oxygen? So you know nitrogen is 70%, for example, and then oxygen is 21%. So I read on a paper that it says that, so anything, for example, if you supply a 21% or roughly 20% of oxygen, the FiO2, you have to minus by 10 kilopascal. So basically, if 20%, then it is equivalent to 10 kilopascal because you have to minus by 10. So when 10 kilopascal basically means 75 mmHg. So my question is, contoh, if I gave a patient, I gave them oxygen, not under room air, I gave them oxygen, and then the FiO2 is 30%. So what is the expected of the PaO2 if you were to measure the ABG of the patient? So assuming that it is 2 times, because you minus by 10, so then it is become 20 kilopascal, which is 75 times 2, which is 150. So, do you guys understand that part?
Oh, meaning that it's already in excess.
Yeah, it's already in excess. So is that really good? So I
No.
asked the MO yesterday. They said that it can be, it depends. It really varies. You have to see if the patient, they memang tolerate it or not, or maybe they cannot tolerate before this, even though in 100 mHg, they seems like have difficulty. So he said that we can supply more than that. It is really depending on the patient. And when you want to give Nesapron, for example, can you give Nesapron, you give 1 liter per minute, 2 liter per minute. You don't give them by fraction of inspiration oxygen, like 30%. You don't give it by that. So how do you want to know that 1 liter per minute is how many fractional inspiration of oxygen? So there is a list that I put down here. You can see. This one. This one you can see is that if I give a supply of 1 liter, then it will be 24%. If I give 2 liter, then it will be 28%. So let's say if this, let's say I want to give 30%, then I give 3 liter per minute. If I give 3 liter per minute, it is 32%. And then I minus 10, which is roughly 20, then this 20 times by 10. You took 2, then equal to 20 kPa. Then is equivalent to. But usually, if your patient memang have very low hypoxemic already, and then you give them this, usually they would be, of course, still lower than 100 mmHg because even in under room air also, they also have difficulty already in breathing in. So, there you go. Next. So, okay. So how do you want to decide if this patient is having respiratory failure? So if it's below the 75 mmHg, you already said that this patient have hypoxemia. But then if it's lower than 60, then it is said that it is in respiratory failure. So how do you want to differentiate first type and second type respiratory failure? So first type respiratory failure, you talk about the VQ mismatch. So you learn back then, this is your alveolar, then you have your blood vessel. So your VQ mismatch is really depending on your perfusion and then depending on your ventilation. So in cases like contoh, your VQ mismatch is like it doesn't match. So then your body will increase your ventilation. So when you increase your ventilation, you allow more oxygen, you allow more carbon dioxide to be removed, but you don't allow more oxygenation to your red blood cell. This is more like the physiological, because if you see the dissociation graph and everything that you learned in physiology back then, the carbon dioxide and oxygen itself is different. That's why even if you increase ventilation, you allow more CO2 being removed. It does not mean that you can increase oxygenation of your red blood cell. So when you see this? You see this in cases of pulmonary edema, embolism, bronchoconstriction. And then embolism, which one they affect? They affect your perfusion. Bronchoconstriction, they affect your ventilation. And then on type 2 respiratory failure, you have due to alveolar hypoventilation, you cannot oxygenate, you cannot remove CO2. So just now you can have a normocapnia, but now you become hypercapnia because you cannot remove CO2. And you see that in COPD, you see that in people with respiratory muscle weakness, for example, neuromuscular issue, they have reduced compliance tissue in chest wall, and then in cases of people with they're on medication. Okay, so for the parameter for carbon dioxide, so of course we already know from this equation itself, carbon dioxide, they will become more acidic due to the carbonic anhydrous. So by seeing the PaCO2, you can determine whether it is a cause because of the respiratory causes, because you have metabolic causes, respiratory causes. Even the name itself is already saying respiratory, so of course it is involving gas first. So if you look at bicarbonate ion, it is a metabolic causes of acidosis or alkalosis. What does bicarbonate ion really do is that sometimes, because they act like a buffer, so if there is a high hydrogen ion, it allows them to bond with hydrogen ion, which reduces the free hydrogen ion. Because even in chemistry also, free hydrogen ion is the reason of the changes of pH. So now, the fourth parameter, which is the pH. Using the pH, you can know that 7.35 lower acidosis, 7.45 upper alkalosis. And from here, it's your job to decide if it's a metabolic cause or respiratory cause. So remember when you learn about the Henderson-Hasselbalch equation, you don't have to really know that, but you have to know this bicarbonate over carbon dioxide. So contohnya, your pH, let's say your pH is contohnya, let's say if your pH, let's say like this, and this is ion in gas, for example, this is CO2, and this is your HCO3. So if this maintain normal, then this is high, then your pH should be low. Reverse proportion, not directly proportionate, right? So if this is low, then this is high. But if this is low, then pH is low. But if pH is high, your bicarbonate is high, but with the syarat your bawah is normal. Just basically play with the equation. So this is the fifth parameter, the best excess. When I asked the MO, they said that it's not like a very significant thing you want to look at. So just roughly go through. If you have a high best, then indicate there's a higher than normal amount of bicarbonate. The name itself, best, right? Bicarbonate ion is the best. And then if there's low best, then there is a low bicarbonate ion. So how do you want to determine? How do you want to interpret your ABG? So first, you look at your pH. Let's say your pH is low. Acidosis lah, kan? So if you acidosis, so you determine. This is respiratory opposite metabolic equal. So maksudnya, if your pH is low, it is expected your CO2 to be high because opposite. If it's a respiratory causes, if it's a metabolic causes, then you have bicarbonate ion also low. Same goes to alkalosis. It's just opposite way. And then how do you want to do? How do you want to determine if it's compensated or not? If it's partially compensated, there is a changes of your bicarbonate ion. If it is a metabolic acidosis, there is a changes to your carbon dioxide. Because if you have a problem, respiratory, of course, your respiratory cannot compensate. You have to use your kidney to compensate. But if your kidney having problem, your kidney cannot compensate. You use your lung to compensate, like that. Do you guys understand this part? And then if you have low pH, right, so you have higher carbon dioxide, which means that supposedly your bicarbonate ion, in order to compensate, they have to increase your bicarbonate ion because your bicarbonate ion is a base. So they can buffer more hydrogen ion. But if your pH is acidosis due to low bicarbonate ion, then of course you have to increase ventilation to reduce your CO2 because you don't want the production of more carbon dioxide. Same goes to alkalosis, it's the same thing. So how do you want to make sure it's partially or full? Partially is because if after all the derangement that happened, your pH can still fall between this range. But if you have changes of your CO2, you have your changes of bicarbonate, but your pH does not fall on the normal range, it is called partially compensated. So these are the differential diagnosis is the differential diagnosis if you decided this patient is respiratory acidosis or respiratory alkalosis. And then this is differential diagnosis for metabolic acidosis and metabolic alkalosis. For the alkalosis, you can just use the mnemonic lah. Mnemonic. I don't know how you call it, but you use this. So vomit, then you use V for vomit, O for overcorrection, mineral corticoid, iatrogenic, then you use total volume loss. So you don't have to memorize, you just use this. But this special case, just now all the thing, I give a differential diagnosis except for metabolic acidosis, right? But because metabolic acidosis, you have to determine whether this patient is due to increase of hydrogen ion production or there is a maybe increased removal of bicarbonate ion. So you have to determine. So how do you want to determine if you use the anion gap? So anion gap, you use this calculation. So all these parameter, the sodium, chloride, bicarbonate is already in your ABG later. And then if the calculation is more than 12, then it is high anion gap metabolic acidosis, meaning that it is more inclined or more related to due to increased hydrogen production, for example, the proton production. For if you are under NECMA, which is normal anion gap metabolic acidosis, then it is maybe due to increased removal of bicarbonate ion. So this one also you can use. You can also use this hard up renal, but this one renal tubular acidosis you have to go back and study because there's 4 types of renal tubular acidosis and it affects your different cell interconnected or different part of your nephron differently. And another one for high anion gap is McHouse. Can anyone tell me any example of salicylates? Aspirin. Right. Okay, so I'll go to example. So just now I said about the mid. So example, the very first example we look at is zoom to the most left one. You can see that it is a non-specified sample. So how do you want to determine if this is a venous blood gas or if it's a arterial blood gas? You look at the P PO2. Since the PO2 is very low, and then if you see the patient is stable, then it means that this is venous blood gas. It is not arterial blood gas. And this is an example I said just now. So this patient, you look at the oxygen, 127 mmHg. This patient is having FiO2 of 40%, 0.4. That's why it have a relatively higher than 100 mmHg of oxygen. Okay, so I have two questions. I have two situations. The very first situation, do anyone wants to answer, or I just do it? Okay. Okay, so in this case, you see I prefer to look at the pH first. So you look at the pH first. So the pH is already low. And then the oxygen is high. Then the carbon dioxide is low. And then the bicarbonate ion is. So if pH is low, it already means acidosis. And using the ROME, ROME, the pH is decreasing as well as the bicarbonate ion.
Metabolic.
Metabolic, yes, metabolic acidosis. And then there's a decrease of the carbon dioxide too, right? So it is a partially compensated because your pH does not fall on the normal value, but then there is a changes of your carbon dioxide level to compensate with the losses of your bicarbonate ion. This one, do you guys want to do it yourself, or do you want to discuss? Since we don't have that much time, I think you guys can do it yourself, and I can give the answer in the group later on. Oh, but I want to discuss the last part because I want to discuss the last part, the last question. The last question, the 7.38 will fall from into pH is normal range, right? pH is normal range. Then this is a CO2. And the CO2 is low. So the oxygen is normal range. And the bicarbonate ion is low, 22 to 26, right? So when your pH is normal, it doesn't mean you have no problem lah. So since you already see there is a decrease of carbon dioxide, and there's a decrease of the bicarbonate ion, since the changes of we would say this is a metabolic acidosis. Why it is fully compensated metabolic acidosis is because your bicarbonate ion is more affected than your carbon dioxide because it is 22 to 26. And then furthermore, it is easier to compensate through respiratory. If you have metabolic causes, it is easier for you to compensate through respiration. If you have respiratory causes, it is harder for you to compensate, or longer time taken for you to compensate metabolic. So I think that's all from me. Thank you.
Daniel, I think I want to ask something. If we know the pH is already normal, then how do we like want to know if it is respiratory or
This is the one I want to discuss because I actually want to ask doctor this question because from what I learned is that they said you see which one is more affected. Contohnya like just now kan this is both pH is normal but both carbon dioxide and bicarbonate ion is low. And then after that kan this video said that because since the bicarbonate is more affected than the carbon dioxide lah, so it is said that the bicarbonate ion is the causes of the metabolic acidosis. However, there is a decrease of carbon dioxide due to the compensation to the situation itself. That is what it says. But I also wondered the same question actually.
Okay, okay. Maybe you can ask doctor.
Hello, have you finished your presentation?
Yes, doctor, for my part, I finished it. I want to ask about the number 4 question. The number 4.
Okay. Can you go back to your case number 4?
Yeah, already. So the 7.38.
Okay, your question?
My question is, for example, this patient is already fully compensated, so the patient already fall in the normal range. So then there is a decrease of carbon dioxide, and then there's a decrease of bicarbonate ion, right? So how do we want to decide whether the causes, whether it is the metabolic or respiratory causes, since the pH is already falling on the normal range?
So this one you can say compensated. But the oxygenation wise is okay, right?
Yes, it is within normal range.
You can say compensated metabolic acidosis, and then you have to see at your case as well. Ada let's say lactic acidosis, right? How about renal function?
So
Then
use this as like
we
a
decide.
guidance.
Yeah,
Use
yeah.
this as a guidance.
And then usually if for respiratory acidosis, you have to see for your CO2.
Understand, doctor?
You get me? You have to
Yes.
see at your carbon dioxide, and then for the case itself lah. Okay, I want to comment for the first presentation. Can you go to your first slide? Not this pleural effusion interpretation. Okay. Which page, doctor? Okay, regarding the pleural effusion, so what is the most important thing you have to know? Either it exudative or transudative. So can you mention again about light criteria? What have you remember about light criteria? So light criteria is a criteria used to diagnose to differentiate whether it is transudate or exudate. Basically, if it's the ratio of pleural to serum protein is less than 0.05, which is low, it is considered as transudate. If it's more than or equal to 0.5, it is considered as exudate, which exudate contain more protein and LDH level as there is increase in capillary permeability. So bigger components such as protein and LDH can pass through and enter the pleural cavity. Okay, now previously we previous for the previous that we also we also call this question as this one is like criteria. Previously we need to have 2 out of 3, but now only 1. We can diagnose either it's exudative or exudative. Hello.
Understand, right? This one, we only have if we have one criteria, so we can differentiate either it's translated or executive. We don't have do not have to have more, two or more lah. Understand kan, Jenny?
Yes, Doctor.
Yeah. So, and then we from transudative exudative, we can differentiate between either the main causes, either it is infection or tuberculosis or any malignancy. Okay, I think this one, regarding to the equation, this one we have to differentiate identity as relative, and then we have to know the causes because the treatment and the management is different. Okay, next. Your next slide. Okay. Next. Okay, and then the color is also important, and the LDH as well is important. Did you mention about ADA? Plural ADA.
I do not mention about ADA.
Do you know what is ADA? Have you ever encountered before?
No.
Actually, we also can send ADA, plural fluid ADA, but ADA is not available in HSM. We have to send to private lab such as a PET lab or Gribble. Actually, we can send if we have high suspicious of TB. Actually, we can send for ADA. However, the result is about 2 to 3 weeks lah. One of our differential, one TB, we can send ADA. It's also sensitive for rural TB. But we have to send as usual lah. MTB CNS, gene expert, that's one book we can send as well. The next. Okay, this one is okay. Actually, do you know the format of OSCE? Have you been taught about OSCE before?
In medical, not yet.
Not yet. Because actually, I also knew this last week I went to vetting lah, and then I learned I know about OSCE session. Actually, the OSCE session, your OSCE is same with final pro, right? Is it different format or same format? I think they will use it the same format lah. Actually, they will give each session for 10 minutes, and then either you will have a simulated patient, and then you are given example a picture, chest X-ray, ECG, or even pleural fluid result, and then you have to interpret. They will give you a short summary, example. 70 years old, layman, active smoker, background history, diabetic hypertension, and then presented with shortness of breath. And how you approach this patient. And then they are given few minutes to get the history, and then they will give let's say this is the X-ray of this patient. Let's say they give to infusion, and then later on they will give this is the pleural fluid analysis, and then you can analyze from that, and then answer just another few more questions. Let's say how to confirm this, how to confirm the diagnosis, like that lah. But it's only for 10 minutes. Okay, for ABG, okay, I think that's all for pleural effusion. So for ABG, actually you have to differentiate either it is respiratory failure or metabolic causes, and then you have to know type 1 respiratory failure and type 2 respiratory failure and the causes. And then how do you want to, let's say, upgrade from, let's say patient had type 1 respiratory failure on Ventimas 50, on Ventimas 40%, and what is your next approach? Your high flow mask, so NIB, but this one you will learn more on oxygen delivery, right? There will be another session for oxygen delivery, right? So this one for HBG interpretation in OSCE, they also can ask a short clinical scenario. Let's say patient presented with shortness of breath, SpO2 under room air only 70, and then they give the ABG result and ask you to interpret the ABG. Any question? Do you have any other question? If no, I think we can end our class today. This evening, yang CBL tu, you will be in the same group, right? For another group.
Another group, Doctor, smaller group.
Smaller group. Okay, so you will see in Thursday, on Thursday tomorrow at 2 to 3. Okay?
Doctor,
Yes?
I'm Adrina. I have a question.
Mhm.
Is there a significance to know normal anion gap and abnormal anion gap metabolic acidosis?
Actually, okay, about this one. Actually, you have to know what is the reason, because the causes for high anion gap and normal anion gap is different, right? Do you have the causes here in your slide?
Yeah.
You just remember about the significant one lah. High anion gap usually DKA, uremia, acidosis. Yang common one lah. Normal anion gap usually diarrhea, and then pancreatic visceral, meaning they are losing, and then RTA, because the difference make the treatment make it different lah. This between normal anion gap and high anion gap metabolic acidosis.
All right. Okay. Thank you, Doctor.
Okay. Okay, see you tomorrow. The next topic, what we have, just X-ray, right? X-ray and oxygen delivery, and one more. For tomorrow,
ECG, Doctor.
ECG. Okay, okay. Okay, anything you can ask me tomorrow, right? Okay, thank you. Assalamualaikum.
Thank you, Doctor.
Thank you, Doctor. Thank you, Doctor. Thank you, Azra.